Hi, welcome to Big Time Care for Little Bones. This is a two-part series on common pediatric orthopedic problems in kids. In this first segment, I will go over some of the most common pediatric orthopedic problems that we see in newborns and toddlers. So first, a little bit about myself. My name is Eleaine Tran. I'm a pediatric orthopedic surgeon at Cohen Children's Medical Center, Northwell Health. I see patients all across Long Island and Staten Island, and I operate mostly out of Cohen Children's Medical Center as well as Staten Island University Hospital. For those of you who are curious about my educational journey here, or perhaps have kids or family members that are interested in a career in orthopedics, my journey consisted of 4 years at Brown University for undergrad, 4 years at Albany Medical College for medical school, 5 years at Albany Medical Center for orthopedic residency, and finally a year at Texas Scottish Rite Hospital in Dallas for pediatric orthopedic fellowship. Now I know 14 years is a long journey, but it's definitely worth it. I have so much fun every day seeing kids of all ages, from the most adorable newborns to kids who are ready to go to college. And pediatric orthopedics is an amazing, unique field where treatment options can change and vary from simple bracing to more complex procedures just based upon their age. As I mentioned, I see patients across Long Island and in Staten Island. I'm one of 8 pediatric orthopedic surgeons. Our main office is in Lake Success, and we have 6 additional satellite offices, including Garden City, Belmore, Bayshore, Westchester, Manhattan, and Staten Island. So what makes little bones so unique? Kid bones differ from adult bones because of many different factors, and understanding them really helps to understand how to treat kids. Some of the main things that we look at is that they have open growth plates. So obviously your young child is still smaller and growing until they're adult size. Growth plates are made out of cartilage, and it allows the bones to get longer as they get older. Slowly as they get older, the cartilage thins out until the growth plate completely closes. And at that point, we call them skeletally mature. There's also something called the periosteum. So everyone has periosteum. It's the lining of the bone. It's much stronger and thicker in kids, and it has many functions. One is that it can help to maintain the reduction of a fracture. So fractures are broken bones, and sometimes fractures can happen where the bone doesn't move, or sometimes fractures can happen where the bone angulates, or it shortens, or it twists. And so the lining of the bone, the periosteum, can help to hold the bone in place after it's been put back into a good position. It also supplies the bone with nutrients that are needed to help with bone healing. Kids heal much faster than adults, and it can also help with bone remodeling. Another unique factor about kids is that the bone consists a lot more of cartilage than in adults. We all have cartilage everywhere, but in particular at the ends of the bones in kids, when they're first born, a lot of it is primarily cartilage. As they get older, the cartilage will slowly turn into bone. But what makes them so special is that when you have disorders that can cause the cartilage or the shape of the bone to be abnormal or flattened, you can just place the bone into a good position, and it helps to remodel the cartilage. Whereas in an adult, if there's changes in the bone shape, because it's primarily all bone, you aren't able to do these same things. And so there's also, similarly, the remodeling potential of kids. So a lot of times we'll see fractures in the office, and in young kids, we can see the fractures bent or angulated, or what looks like a crooked x-ray, but we don't get too concerned because we know that as they get older, they can grow the bone straight. So next, I'm just gonna go over the different problems that we're gonna talk about today. So in newborns, we're gonna go over some birth injuries, developmental hip dysplasia, clubfoot, torticollis, and curly toe. And in toddlers, we're gonna talk about bowed legs, in-toeing, toddler's fractures, and nursemaid's elbow. So starting out with birth injuries, although these are not as common as some of the other conditions that we'll be talking about today, we do see a handful of these cases every year. The overall incidence of birth injuries ranges from roughly 0.2 to 0.6% of all live births. The most common orthopedic birth injuries that we see are traction injuries, meaning a stretch injury to something called the brachial plexus. So the brachial plexus is a confluence of your nerves that come out of your neck, and they form 5 main nerves that help innervate all the muscles and sensation in your arm. And in addition to brachial plexus injuries, we commonly see clavicle fractures. We can also see other fractures like humerus fractures, which is the arm bone, and femur fractures, which is the thigh bone, but those are much less common. Why does this happen? So there are a variety of factors that can cause birth injuries. Typically, it's because the baby is not in a great position for delivery. And there can be a lot of pressure that gets put onto the shoulder area. We can see it more in premature births or if there's prolonged labor. And there are also some maternal factors that play a role, such as the size and shape of the pelvis and the birth canal, and also obesity. For difficult deliveries that require manipulation, such as using forceps or vacuum, we can obviously see higher rates of these injuries. So some signs of a birth injury include some mild swelling. Usually it'll be decreased movement of an arm or a leg, perhaps asymmetry in how the arm and legs are moving. So one side may not be moving as much as the other side. The position of the arm may be held in a different position as the other arm. Overall fussiness that can't be attributed to anything else. And even sometimes, a couple days later, you may notice a bump on the clavicle or the collarbone or the arm or leg. And that's because babies heal the fastest out of all of us. And so what do we do for treatment? It really depends on what the injury is. Oftentimes, if there's concern for a fracture, then x-rays will be ordered. And treatment at this age typically is observation, some sort of wrap, like a swaddle to help keep the arms together if there's a clavicle fracture or even a humerus fracture, or something called a Pavlik harness, which is put on for femur fractures. If there's a brachial plexus injury, this is just something that will be followed as your baby gets a little bit older. Your baby will be seen by an orthopedic specialist to observe for return of the function of the muscles that may have been affected by the nerve injury. And this is just a cool example of fracture remodeling in kids, as I discussed earlier. So this is an x-ray of the humerus bone, again, the arm bone, and there's a fracture, and you can see my pointer here. There's a fracture in the middle of the humerus here. Now, on the first day that the x-ray was taken, you can see that the bone is a little bit crooked. It's not perfectly straight, but it's not terrible. But by the second day, the bone has kind of slid off and shortened a little bit. But again, this is nothing that we get concerned about at this age because of the remodeling potential. And so you can see by day 7, there's this giant ball around the fracture. This is called fracture callus. It's literally a ball of new bone that is forming around the fracture site. It'll happen wherever there's a fracture. So on the collarbone in particular, you will be able to feel this bump because the collarbone tends to be very subcutaneous or just underneath the skin. Even on the humerus, if you're kind of comparing the two sides, you would be able to feel a difference and feel that bump of bone there. And at 2 weeks, you can already see that the new bone has started to kind of consolidate into the primary bone. And then by 6 months, you can see how it looks just like a normal bone. So it's pretty incredible how the bone can continue to heal and change shape and remodel until it looks normal. Again, newborns have the highest remodeling potential. Young kids still have, an excellent amount of remodeling potential, and that does eventually go away when you become an adult. So the next topic, this is a very common orthopedic condition, developmental hip dysplasia. So what is this? First, it's the most common orthopedic disorder that we see in newborns. It's really a spectrum of conditions that involve the development of the hip in a newborn. It ranges from where, if you think of the hip joint as being a ball and a socket, it ranges from where the ball is in the socket, but the socket's a little bit shallow, to where the ball is in the socket, but it's a little bit out or subluxed, to where the ball is in the socket, but you can dislocate it because there's some instability there, to where the ball is out of the socket, and so it's dislocated, but you can reduce it, to where the ball is stuck out of the socket or stuck dislocated. Again, it's a huge spectrum of conditions. The treatment really varies depending on how severe the dislocation is. And the important thing is that if the ball is not in the socket in utero, or the ball is not in a proper position in utero and in early development, then the socket doesn't have the stimulus from the ball to form a proper shape for a normal hip joint as an adult. So that's why there's so much screening that is done to try to find these cases very early on, because again, newborns are the most unique, and we're able to treat these conditions with much more simpler techniques than if this is found when they're older. So how often do we see it? We see dysplasia, meaning the shallow socket, in about 1 in 100. We see a dislocated hip in about 1 in 1,000. And there are known risk factors that are associated with hip dysplasia, which include breech presentation, being firstborn, female, family history, and oligohydramnios, which is when you have less amniotic fluid. It's also associated with other what we call packaging conditions. So this is another reason why it's more common in firstborns, because there tends to be less space in the womb. So other associated conditions include torticollis, which is a tight neck, which we'll talk about later. Metatarsus adductus, which is a change in the shape of the foot. So that's what this picture is on the left. All the way on the left is a normal foot. And then on the right, we see the metatarsus adductus. So the metatarsal bones are these bones in this part, or the forefoot of your foot, right here. And adductus means curving in. So that's how it has like almost like a kidney bean shape rather than a straight shape. So what are some signs of developmental hip dysplasia? So from the moment that your baby is born, your baby will be seeing a lot of doctors, and they're going to be checking many things, including checking the hip exam. So babies less than 3 months, joints and everything in general, they're much more loose. And so we're able to utilize this to examine the hip. If there is hip dysplasia, then sometimes we can feel the hip sliding out of the socket. We can feel the hip dislocating out of the socket, or sometimes we feel that the hip rests at a dislocated position and we're able to reduce it. And so these are the different exam maneuvers that are done. And don't worry, it's not painful or harmful to your baby. It's not done with excessive force or pressure. It's just when there is hip dysplasia, we're able to easily kind of slide the hip in and out of socket. Your pediatrician may oftentimes talk about clicks or clunks that they feel. A click is not necessarily the same thing as a positive finding. So a lot of times when you're doing diapering changes or maneuvering the legs, you might feel a click around the legs. And oftentimes that's just the soft tissue or the tendons kind of rubbing or passing over. And it's not really the hip sliding in and out of the socket. In order to feel that, the hips have to be positioned in a very specific way that your orthopedic provider can do. As they get a little bit older, those exam maneuvers, so they were called the Ortolani and Barlow maneuvers, they become less reliable because obviously everything's tightening up a little bit. So from around 3 months to a year, we'll use other findings to try to see if there's any concern for dislocated hip or for hip dysplasia. And one of them on the bottom left is when we frog leg out the legs. So bringing the legs out is called abduction. When we bring it out, the side that is affected doesn't have that same motion because it's not in the socket. So it gets stuck. So when you try to frog the legs out, it kind of stays higher up than the other side. So you'll see an asymmetric motion at the hips. Another thing you can see when the child is laying down and you measure the knee heights, if the hip is dislocated, that dislocated hip will be shortened because everything's moved up towards the hip. And then asymmetric thigh fold. So this is another very common referral that we get from pediatricians to evaluate for hip dysplasia. The reason why it triggers a referral is because you can see on this picture on the right here. So on the right hip here is affected. So if the ball is dislocated, the ball is out of the socket, the whole leg becomes functionally shorter. When the whole leg is functionally shorter, then you can have more thigh folds. But asymmetric thigh folds is a very non-specific finding. If your baby has that, I would not be concerned, but certainly if your pediatrician recommends referral to see us, we're happy to see you. And so what do? We will initially ultrasound your baby to check their hips. The reason why we ultrasound babies is because the ball and socket, the ball has not yet turned to bone. So if we got an x-ray, we don't see anything there. It's kind of like a space because the cartilage doesn't show up on the x-ray. So we always get ultrasounds in newborns. We will get an ultrasound of the hip if there's an abnormal exam. So if there's a positive finding. We'll get an ultrasound also of the hip if you have a risk factor such as breech presentation or family history. Usually that ultrasound screening for just a risk factor, but otherwise a normal exam is usually done at 6 weeks. But again, that will be dependent on your orthopedic provider who will take a look at the whole history and everything. When babies get going back to the ultrasound, so this just kind of reorients the diagram of the ultrasound. And I like to always show patients this in the office. So every ultrasound initially is pointed in this direction, whether it's the right or left. It's kind of like a sideways view. But if you really want to think about how the ultrasound relates to the pelvis, you can see here that this line that you see on the ultrasound corresponds to this part of the pelvis. This line over here corresponds to the socket of the hip joint. The ball, the circle, obviously corresponds to the ball. And then there's different measurements that we make off of it, including looking at how much of the ball is under the socket and what angles are measured of the bony component. Now, x-rays are usually done in older babies, so, at 6 months, maybe a little bit earlier. Again, the reason why we wait is because the ball is still primarily cartilage when babies are much younger. On this x-ray, you can actually see that the ball is starting to form. So you see the circle. It's called ossification when the cartilage turns to bone. And the right side, this side here, is the one that's affected. So on the right side, because the hip was dysplastic, I'm not sure of the history, if it was dislocated and then reduced with a harness. But regardless, because the right side is developing behind the left side, the ossification or the ball is smaller than the left side. So there's a slight delay. Again, it's so important for that ball to be in the socket for the hip joint to develop properly. The other thing you can see is that if we look at the socket or like the roof over the ball, on the right side, it's almost vertical, or it's much more vertical, and that's the dysplasia or the dysplastic acetabulum that we see. Acetabulum meaning the socket. Now, how do we treat developmental hip dysplasia? Generally, in kids less than 6 months, we'll start out with a Pavlik harness. It's not the fanciest device, but it's a very simple device that is very effective in treating hip dysplasia, which is pretty incredible if you think about the condition. If you think about a hip being dislocated, you would never be able to get that to reduce in an adult or an older individual or even an adolescent with just putting on a brace. So again, it's not the fanciest device. It's usually not very fun for the parents to take it on and off. But if you think long term of how you're able to have such a strong impact on the hip joint with such a minimally invasive tool, it is very exciting that we are able to do that. Sometimes if the Pavlik harness is not working, then we might switch over to a rhino abduction brace, which is a little bit more rigid. And if that's not working, and the hip is dislocated, we might have to defer to surgery. Surgery can be as simple as putting the hip back in the socket and putting a cast on, to actually making an incision to help put the ball back in the socket, to also making cuts in the bone to reshape things. Again, the older a kid is, the more complicated it becomes, or just the more involved the treatment becomes. But in newborns, they have an incredible potential to respond very well to just bracing. So the next common orthopedic condition we're going to talk about is clubfoot. The other name for clubfoot is a fancy term called talipes equinocavalovarus. That word just describes all of the changes that happen in the clubfoot. This is a very common idiopathic condition that we see in newborns. And it's important to note that it's a rigid change in position of the foot. It's not flexible and it's not positional. So a lot of times when the babies first come out, because they've been packaged tightly in the womb, you'll see that the feet kind of turn in. Babies can even have something called a positional clubfoot, where the foot kind of stays like this at rest. But the difference between a positional clubfoot and a true clubfoot is that in a true clubfoot, you can't just bring the foot back up into a normal position. You can't bring the ankle back up. They're really, really stuck. And so, if there's any concern, obviously have us take a look and evaluate. But if you're seeing your baby kind of naturally on his or her own, bringing their ankle up, you don't need to be concerned. A lot of times the clubfoot is bilateral, meaning it occurs on both sides. We don't know exactly why it happens. We do know that there tends to be a strong genetic component. So families who have one child with a clubfoot have a much higher chance of having another child with a clubfoot. But again, we don't know the exact cause of clubfoot. And the reason why the foot is turned in that position is because the muscles are all imbalanced. There are a lot of bony changes that occur, meaning the position, the alignment of the bones is very different in the foot. And anytime I'm, talking to families about a clubfoot, I explain that the clubfoot side, although we can do many things to get the foot to be in a good flat, or what we call a plantigrade position, the clubfoot is never exactly the same as the other side. But we should be able to get your child to be able to do everything, have no functional limitations, be able to play whatever sport he or she wants to do. So some signs of a clubfoot. These are signs that you'll notice more as your child gets a little bit older, but the affected side, or the clubfoot side, the calf muscle is always smaller than the other side. If both sides are affected, then you won't notice this as much. But if you only have one side that has the clubfoot, you will see the difference in size of the calf. Sometimes the leg bone or the tibia can be a little bit shorter than the other side. And at birth, there's very characteristic creases that we'll see in the foot. And also we see the turning of the foot in a very specific pattern. Now, treatment for clubfoot. So we do something called serial Ponseti casts. This is a technique that allows us to actually stretch the foot into that plantar grade or flat position. Every cast is designed to work on a specific part of correcting the foot. So each cast kind of looks funny in its own way until the final cast when you're finally bringing the foot up. We have a lot of excellent success with Ponseti casting, but not every clubfoot is the same. So some club feet are less severe, some are more severe, and there are also complex club feet. Typically, after the final Ponseti cast is put on, there will be a heel cut or a tenotomy, so a cut of the Achilles tendon, which is the tendon in the back of your heel, and that helps to bring the ankle up into a good flexible position. That will be followed by a final cast that's usually on for 3 weeks, and then your baby will transition into braces that you can kind of see in this bottom picture here. The braces are very, very important to wear to prevent the clubfoot from recurring or from coming back. And then sometimes we do have to do some additional surgical procedures when the child is a little bit older, including sometimes a tendon transfer to help with the walking. And if there's any recurrence or tightness of the ankle, we might have to add additional procedures. Next, we're going to talk about torticollis. So again, this is one of the packaging conditions or packaging disorders. So torticollis is a tilt of the head. There are many different causes of torticollis. The most common one that we see is something called congenital muscular torticollis. And it's a tightness of a neck muscle. It's called the sternocleidomastoid. It's your neck muscle right here, and you can kind of see it in this picture here too. It's a tightness in that muscle that causes a very characteristic head tilt. It's the most common cause of infantile torticollis. And again, it's a contracture or tightness of that muscle. So how does it present? On this image here, you can see that muscle very, very, very pronounced. So because it's tight, what it actually does is it causes you to tilt towards the tight muscle, but turn your chin away from that tight muscle. So you kind of are looking away from so say if it was my right side, my head would be stuck turning to the left, but tilted to my right. And as far as treatment, generally newborns respond very, very well to physical therapy. There are a lot of things that you can do at home that a therapist can show you. You want to encourage your child to kind of look in multiple directions. So they'll have the preference to kind of look whichever way, but you'll try to position yourself or position toys so that they're encouraged to keep turning the opposite way. And then there's some stretches that can be done to help stretch out that muscle. If there hasn't been any response to stretching, then you can always release that muscle, but that's much less common. And then lastly, for newborn conditions, I'm just going to briefly talk about curly toe, which is a common thing that we see. So what is curly toe? So it is a common congenital condition that we see that is because of tightness of a flexor tendon or flexor muscle. So you have muscles obviously everywhere, and the muscles extend to tendons, and the tendons attached to the bone. And that's what allows you to move all your different joints. On the bottom of the foot, you have flexor muscles and tendons that attach to the tip of the toes. And so when you flex or bend your toe down, that's called flexion. When you straighten your toes up, that's called extension. So it's an imbalance of the two where the flexors are tighter, and it causes usually the outside toe, so either like the third, fourth, or fifth toe, to curl underneath its neighboring toe. Oftentimes we'll see that it's on both sides so that it is bilateral. And typically we just observe these. You can try just like stretching on your own. If it causes skin irritation or like sores from the neighboring nail kind of digging in, we could always talk about surgical release of that tendon when kids are a little bit older. So next, we're going to move on to common pediatric orthopedic problems in toddlers. A very, very common problem that we see is bowed legs. So there are actually a lot of changes that happen in a child's legs as they get older, a lot of natural changes that occur. So a simple way to kind of think about the timing of it is that usually at age 1, we see that the legs are bowed. And we call this physiologic varus. Varus refers to the legs or the knees being bowed. Valgus is the opposite, where the legs are knock-kneed. Physiologic just meaning it's normal. As the child gets older, that bowing should slowly go away until the legs are straight by age 2. And then it should continue to go in the opposite direction where the knees are a little bit knock-kneed by age 4. And then after that, slowly, the legs kind of straighten out to the adult normal alignment, which is a little bit of knock-kneed. Not as much as what we see at age 4, but just a little bit of being knock-kneed. Now, physiologic varus or physiologic bowing is different than pathologic bowing. So there is a condition called blounce that we can see in infants and also in adolescents. And this is much different than physiologic varus because it does not get better on its own. It's usually because of an unhealthy growth plate, unhealthy bone on the inside part of the knee, so kind of where the arrows are pointing here. So here we have both legs. At the top are the femurs, or the thigh bone, and then below that are the tibias, the shin bone, here and here. The lines that we see, these are the growth plates. Again, growth plates made out of cartilage, so that part's invisible, here and here. And the shape of the bone, the shape of the growth plate is not healthy. It kind of tips down, and that's what causes the bowing of the legs. On the right, you can see a photo of a child that has blounce. The treatment for this is different depending on the severity. We can actually utilize a child's growth and grow the legs straight in less severe cases where the growth plate on the inside is still growing. What we do is we put a small plate on the outside part of the knee across the growth plate. So we don't touch the growth plate, but the plate kind of sits above and below the growth plate, and it prevents the outside from growing. It allows the inside to grow, and then the kids actually grow their legs straight. Once the legs are straight, though, we have to take that plate out, because if we left the plate in, then the legs will keep growing in the opposite direction. But that's another unique, fun way that kids are so special, because we're able to use their growth potential or the growth remaining to correct a lot of these conditions. Next, I'll talk in-towing. This is probably one of the most common things that we see in the office. So in-towing just refers to how a kid walks. It refers to the feet being turned in or pigeon-toed when they're walking. It oftentimes is an annoyance for families because they notice their kids tripping a lot on their feet. They can fall a lot because of it. And so, rightfully so, they bring them into the office to kind of see what's causing it. In general, there are 3 components that we always check in the office to see if this is what is causing the in-towing. The first is looking at the foot. So remember one of those packaging conditions that I mentioned, the metatarsus adductus, where the foot itself is kidney bean shaped. So even if you put your foot straight forward, because it's kidney beaned, it looks like it's turned in. The second more common cause of in-towing that we see in toddlers is something called internal tibial torsion. So again, the tibia is your shin bone. As it comes down from the knee and goes down to the ankle, it can sometimes twist or rotate. It can twist in, it can twist out. Internal tibial torsion is where the tibia literally just twists in. And if the tibia is twisting and then the ankle joint, the foot go with it. This picture in the middle kind of shows how we examine for it in the office. So we'll have your child lay on their stomach and we look at a line drawn down the thigh and drawn down the foot. If the foot turns in like the one in the picture, that's a sign of internal tibial torsion. Don't worry though, because this oftentimes goes away naturally as kids get older. Usually by age 4, we see it resolve. If it does not completely resolve, the only way to change that rotation is with surgery. And we do the surgery in very, very severe cases where kids are really limited by the in-towing just because it is a large type of procedure to be done. And it's where you cut the bone, you're almost like creating a fracture of the bone, you rotate it out, and then you fix it in place. So again, we can do it, but in most cases, we never need to get to that point of discussing it. Now, the last component of in-towing is something called femoral anteversion. It's just a fancy term referring to the rotation coming from the hips. So similar to the tibial torsion, there is some rotation that happens from the top of the femur bone to the bottom of the femur bone. And it's the relationship of the two that will give kids more flexibility turning the hips in or turning the hips out. So kids who have a lot of flexibility turning the hips in, you may see that they like to W sit, or that they, when we lay them on their bellies like this, that we can bring the knees in really far because that's turning the legs in. Versus being able to bring the legs out and turning the knees out. And so because they have more flexibility from the hip turning the leg in, when they walk, they're going to walk with the leg turned in from the hip. Everything below that turns in. There's nothing wrong with it. They have the ability to walk straight, but they're just going to walk with whatever is most comfortable for them. Again, similar to the tibial torsion, it does slowly get better as they get older, usually around age 8. You see an improvement. However, if it does not go away completely, the only way to change it is with a similar surgical procedure, which we refer for very severe cases. Next, we're going to talk about toddler's fracture. So this is a common fracture that we see in toddlers. It's a fracture of the tibia bone or the shin bone only. It's a stable fracture, meaning it's not going to shift or move or angulate or shorten. And it's typically a spiral fracture, which is just a descriptive term of the pattern of the fracture. So instead of a fracture being straight across, it spirals. And usually we see it most commonly in kids younger than 6. It's more common in the early years of walking. And it usually occurs because of a twisting that happens to the leg when a kid is walking or running. Another common cause or mechanism that we'll see is when a toddler is going down a slide and the foot gets caught on the slide and it twists, and it can cause that fracture. Now, what are signs of it? What are things that would kind of cue you in that there's something potentially wrong? Obviously, your child will be crying, refusal to bear weight. So no matter how hard you try to put them up on their feet, they'll just hold their foot up. Because kids are really smart. They're not going to do anything that hurts them. So they're not going to put their foot down. They're not going to walk on it if it hurts. Or maybe they are able to walk, but there's an obvious limp. They could be guarding or painful to specific area in the leg. And sometimes you'll notice a little bit of swelling and a little bit of warmth, but it's usually not anything too obvious. You usually don't see a lot of like bruising or a huge amount of swelling that we would see in some other fracture patterns. So what do you do if there's any concern? Obviously, you want to take your child in to be evaluated. You can take them to see your pediatrician. You can go to an urgent care. You can go to the ER, or you can come to our office. It really just depends on like what is most accessible for you at that time, if it's during the week or over the weekend or after hours. The clinician is going to do an exam, and they'll oftentimes get x-rays. If they are not able to pinpoint where exactly the pain is, they might get x-rays of a couple of the bones. If it seems like it's more the tibia, then they'll x-ray the tibia. And the thing with toddlers' fractures is a lot of times we do not see an actual fracture line initially because the fracture line is so subtle. And so a lot of times we may not see anything on the x-ray. However, if we had you come back in 2-3 weeks and we repeated the x-ray, we would see signs of healing on the outside of the bone, which confirms that there is a true fracture. In general, treatment for this, you have two options. It kind of depends on what you feel most comfortable with and also what the clinician feels most comfortable with. So a long leg cast, so a cast that goes from above the knee at the thigh all the way down to the foot, that will keep your child the most protected. Or sometimes in cases where I don't see an actual fracture line, but the child is limping or refusing to bear weight, I allow parents to just observe the kid because kids aren't going to walk on anything that hurts. I have you avoid any like playground activities or like running around for 2 weeks. And then usually by the time you come back in 2 weeks, the kid's already getting better. Again, it's a stable fracture, so it's not like the cast is holding the fracture in place and preventing it from moving. It's just providing a little extra protection. But kids are very good at sort of self-regulating and protecting themselves from anything that truly hurts. So the last topic we're going to talk about today is something called a nursemaid's elbow. This is another common condition, another common injury that we see around the elbow at this age. Looking at the top to kind of just orient you, so this is an elbow joint. This bone up here, this is the humerus or the arm bone. And then there's two bones in the forearm that meet up with the humerus bone to make up the elbow joint. One of them is the radius, which is on the thumb side, and the other one is the ulna, which is on the pinky side. Now the radius has this band of tissue around it that kind of wraps around the top. It's called the annular ligament. And because kids are more flexible, or their ligaments are a little bit more loose than adults, they have this condition where if you pull the arm, usually you pull it very quickly and the hand is kind of turned out and the elbow is straightened out, it can cause the bone to sublux or come out of position. What happens, it happens most commonly in kids from 1 to 4 years of age. And again, it's because of that sudden pull of a straight turned arm. So if you look at the position of your hand or your forearm, so if your hand is up, we call this supination, like you're able to hold soup. And if you turn down, we call it pronation. So usually it's with the hand, the arm straight and the hand turned or pronated. How is your kid gonna react? They're typically crying. They're guarding the elbow. They're kind of holding it slightly bent and turned or pronated, but they won't let anyone touch them or move them. And the way you treat this is you reduce the bone. So typically your pediatrician will do this because it's so common. An ER provider can do it, urgent care, or in our office as well. And we just manipulate the hand, kind of turn it, flex it up, put a little pressure there, and it pops right back in. Almost immediately after, kids are feeling so much better. They're not crying. They're already starting to use the arm. I hope you enjoyed this short segment about some common pediatric orthopedic problems. And we'll see you next time for Big Time Care for Growing Bones, which we'll talk about more problems that we see in slightly older kids. Thank you.